Good afternoon. This is Matthew Mary, Director of Emergency Preparedness with the Virginia Hospital and Healthcare Association. Thank you for joining us for the Virginia Healthcare Emergency Management Program Quarterly Webinar Series on February 9, 2022. Today's webinar will cover healthcare facility cyberterrorism response planning. A few housekeeping items. All lines will remain muted throughout the duration of today's webinar. If you do have a question for our speaker, please type them in the chat box. We'll have a brief Q&A session following the presentation. Slides are located in the handout section for your reference. The slides and recording of today's webinar will be emailed out to all registrants this afternoon. On behalf of the Virginia Hospital and Healthcare Association, I'd like to introduce you to our subject matter expert for today's webinar, Craig Diatley, Director of Institute for Public Health Emergency Readiness at MedStar Washington Hospital Center. Mr. Diatley will provide an insight and takeaways on developing and updating organizational response planning related to cyberterrorism. Without further ado, Craig, I'll turn the presentation over to you.
Matthew, thank you. And if you'd go to the next slide, please. Good afternoon, everybody, and thank you so much to the association for the invitation to be with all of you today. Also, thank you for giving me the opportunity to talk about something other than COVID. I think we're all kind of tired of that. And yet the subject that we are going to talk about, to me, I think we all will agree is extraordinarily timely, because the threats against our healthcare facility, ITIS infrastructure and its associated applications has never been greater, and the consequences of unplanned outages or being hacked have never been more significant. As Matthew indicated, I am affiliated with a large hospital in the Washington metropolitan area and part of a large healthcare system, MedStar Health. I've for 47 years been responsible for emergency management activities at a number of different hospitals, in addition to being an emergency department clinician as a PA, as well as a pre-hospital provider as a paramedic and EMS supervisor. So it's with that kind of background in mind, and having lived through any number of different planned, unplanned, and one episode of our system being hacked, that I'm going to try and share with you some insights that I've gleaned through my years of service. Next slide, if you would, please. In the short period of time that we have together, I'm going to try and identify a strategy for how you might write an effective response plan, with you describe some key components that a good comprehensive plan might need to address, and then conclude by talking about the training and exercise methods that we might employ to promote our individual healthcare facility staff's ability to use the plan when needed. Next slide. Now, the time that we've been given today, on the one hand, is a good period of time. On the other hand, we're just not going to have enough time to talk about all of the different aspects of planning and response. So I'm going to try and hit the high points, if you will. And I respect that many of you on this conference call today have, through your own experience, potentially lived through planned or cyberterrorism hacks of your own individual healthcare facility infrastructure. And so please, at the end, don't be hesitant to share your points with one another, as well as raise your questions. I'd also like to make a point, one of the most important points of my presentation, and that is that protecting our healthcare facilities from particularly cyberterrorism is not the singular responsibility of just our ITIS colleagues, or just the singular responsibility of us in emergency management, but rather a joint responsibility between not only those two elements within each of our healthcare facilities, but needs to include many other departments as well, operating as one team to be successful. Next slide. Now, to get started, first question is, does your HVA, your hazard vulnerability analysis, address cyberterrorism as a primary threat? Matt, I'm not seeing the follow through after the words "getting started." Can you hit the keyboard again? There we go. So is cyberterrorism somewhere on your HVA? If it isn't, I'd suggest that you might want to give consideration to moving it up into at least a top 25% risk, if not a top 10% risk, because of the threats that continue to grow each day. Next is who should be involved in writing this plan. Suggestions from my experience include, obviously, we need to have the clinical personnel in our respective facilities, the physicians, the nurses, respiratory therapists, representation from the lab and radiology, food services, PT and OT, or some clinical examples. But I would submit also that it's equally important to have non-clinical personnel from engineering, supply chain, security, admissions and registration, guest services, and some other examples to include, and as well address some others that we tend to not think about as readily potentially being affected. Those who work in our parking garage, the cashiers, whether it's in the cafeteria or the gift shop, and of course, our financial services colleagues as well. Next. Now, once we've got this group together, and it can be as large or as small as you want to make it, and one of the considerations that I've gleaned in talking with emergency managers from across the country is some would rather start with a small nidus of individuals, kind of a small representation sample of clinical, non-clinical, and other, rather than get everybody together at once. But one way or the other, by the time the plan is written, you certainly want to have everyone who will be impacted and are to use the plan, vetting that plan before it's approved. And insofar as the plan itself is concerned, are we writing a plan just for our singular healthcare facility? Are we writing a plan that is for our corporate oversight of our individual facilities? Or in fact, are we involved in writing elements of both? Need some clarity in order to get it right. Next slide. Now, some more aspects of getting started include a fundamental question, which interestingly enough, in my experience, both through MedStar, but also in talking with others, each of us individually kind of have our individual idea as to how many applications we use each day. And probably for most of us, that number is less than 10 and would be rather common amongst us probably as well. But in a comprehensive plan, it's not just the ones that we individually use most often. We need to have a composite inventory of what are all of the ITIS applications across the whole of our facility. So instead of that number 10, in my case, I've got nearly 1,000 ITIS applications of one kind or another that we need to have some element of planning consideration being given to. And these are what I would refer to as the supported applications. That is, they are sponsored by the facility or by corporate. But we've also learned from our individual experiences of unplanned outages and that one cyberterrorism attack in 2016, the number of individuals, particularly those involved with research, may have developed their own applications, but yet didn't submit them to be supported by the facility or corporate. And so we refer to those as non-supported applications, and those really should be discouraged, not from being written, but once written, they should be submitted so that they're included in that inventory and part of our planning for how we will deal with their being lost on the one hand and restored on the other. Next, please. Besides knowing all of the applications that we have within our arsenal, it's also important do we understand what do they all do? Next. And how are they all integrated with one another? And also, which of those are aimed at simply our facility operations of one kind or another versus our integral parts of operating our biomedical equipment, which in many cases, increasing cases, for some of us, more and more of our biomedical equipment has some sort of an ITIS integration with an electronic medical record or with an overarching monitoring system. And so we need to understand those applications as well. And in the end, all of this configuration is the responsibility for not being only included in our planning effort, but somebody has to be identified in the plan as monitoring those systems on a daily basis, being prepared to detect an intrusion or a technical failure of the systems, and knowing what to do in response. Next. Now, our focus of a good plan really needs to address a couple of different scenario variations. One in the extreme is all of a sudden, while you're working in front of your computer, you get a message that says, in essence, you are being locked out of your system. You have 24 hours to pay the sum of 30,000 Bitcoin. We've lost it all, and we've lost it all at once. Versus the second scenario a plan needs to be prepared to address is the variation where they've compromised one application, not necessarily all of them, at least not yet. And so how do we handle that situation? And then the third focus of a good plan is going to address the possibility of not only losing our primary programs, if you will, all at once or in pieces, but some compromise to those biomedical systems that are computer connected as well. Next. Now that writing group, however large or small, in whatever configuration, needs to come to a consensus on what's the format to be followed. And in our particular case, we found it to be effective to kind of keep it relatively short, simple, and concise. And so we have at the beginning of our plan a purpose, some key definitions, and then we separate the plan into core content areas, and then attach to that the individual appendices which address the actions to be taken for each of the individual applications themselves. And for each of those appendices, we use a common table format to include the information specific to that particular program. That's just one way to do it. You just need to decide, is that the way that you want to write a plan, or do you have a different format in mind? One thing I would suggest strongly, again, based on experience, is the simpler, the more concise, and the more pithy we can make the information for quick utilization, the more likely it's going to be used the way we want it to. Next, please. Within our core content portion of the plan, we've addressed who has the authority to react to placing a call that something is amiss versus who has the authority, having received that call, to attempt to remediate the issue versus who has the authority and the decision-making power to turn that application or the entirety of the system off. And when we go to the extreme of either an unplanned outage for longer than 2 hours, or certainly if we have been compromised all at once, in our particular thinking, it's important to implement at least a partial hospital incident management team, a team led by the incident commander with key positions within our PIO, within our operations, planning, logistics, and finance administration sections, all being activated and either brought together in person, or depending upon the situation, if it can still be done virtually, then that has some advantage. But some of the time, you're going to have to do it the old-fashioned way, and that is meet in a common room, even though COVID is still a consideration, because we've been compromised to the point that virtual meetings are no longer possible. And for those of us that are also part of a corporate structure, did we make the notification to corporate on the one hand, and two, now are they activating some element of their incident management team design that we will find ourselves having to integrate with as well, should be identified in our plan. Next. Other aspects of getting started. Well, I want to go back to how did we recognize that a problem was afoot to begin with? That typically is going to start with someone who's working at the time, sitting in front of a computer that no longer is operating the way it's supposed to. In our case, any of our staff members, clinical, non-clinical, what have you, who has a problem with their computer not working as expected, we want the help desk to be called. The help desk has a triage system for handling phone calls that reroute the problem to the appropriate authority, and the appropriate authority at different levels has the permission, if you will, to take needed actions, including the extreme action being taken by a mid-level position, interestingly enough, within the corporate structure to turn the system off. Be clear, who reports the problem is one thing, how do we act on the problem is something else. And when we talk about acting on the problem, we want to make sure that we have an assessment that is started on impact on our clinical operations, our administrative programs, the biomedical equipment, even our facility operations. Those are 4 critical starting points, but not the only eventual points for evaluation. And in that assessment, we're trying to look to see what's impacted and find ways to minimize the damage that's at risk for occurring at the same time. And this is an ongoing situational assessment, not simply something that's done at the outset and stops there. One of the things that we've also found helpful across my 2 hospitals that I'm responsible for, and perhaps you have as well, is the quick start card idea of taking elements of your plan and putting the initial actions to take for reporting a problem, for going to the downtime plan, for using the downtime plan, taking some of those critical points from the multiple pages and putting them on a card that's attached to each of the computer desk positions on the one hand and your portable computers on the other. Next, please. Now, once a problem is recognized, the plan should then go on to recognize that there's simultaneous actions that will be happening next, including we've got some core group that are assigned the responsibility for that assessment and trying to remediate the problem as soon as possible in a structured fashion, while another group, the larger group, probably in fact is reacting to the intrusion and still trying to do their day job of providing patient care or supporting patient care activities on the other. And a third equally important activity is going to center around the messaging that needs to go starting to the staff, but potentially be expanded to include others outside of the facility, inside of the corporate structure, etc. Next. Now, we mentioned that incident management team being configured. Among their critical steps is going to be to employ a system of setting that incident action plan, of setting the response objectives, and outlining the tasks to be completed in order for those objectives to be met. Messaging to the staff is one thing when our PA system still works, when our voice over IP phone system still works, when our paging system still works, we would employ that at my facility to try and get the message out. But we need fallbacks for when they're taken out of play because of the extent of the outage. Implementing the downtime procedures, well, you can't just assume that that's what the staff is going to know to do. So messaging not only what has happened, but the initial steps, reminding of them to consult the plan or the cue card or both, we have found to be important, along with that incident management team being the one that facilitates, isn't the only one doing, but facilitates the ongoing situational assessment and bridges, modifies their incident action plan objectives based on successes or new obstacles being encountered. It's also important to understand early in the response that if this was not a planned outage, then is this the result of simply a technical failure, which can happen, we all know, from time to time? A server goes down, an ATS switch goes bad, what have you, versus no, this is clear or highly suspect for a terrorist attack. Now we have a criminal event on our hands, and so we need to be mindful of that. We also need to be mindful that if this was an unplanned situation, if we have any threat or actual harm to patient caring, then now this meets the criteria for a sentinel event. Our incident management team needs to keep that in mind, including making additional notifications we'll come to later. Next. One of the critical things that you'll face, particularly in the all-out compromise, is what can we go back to doing without the technology linkage anyway that we depend upon day in and day out. That should be addressed in your plan. What are the forms that we want our various clinicians and non-clinicians alike to be using as part of our downtime procedure? And does everybody have a common understanding of how these forms are not only to be completed, but where and how they're to be taken and processed accordingly? If you have a backup phone system, is the backup phone system operational? Hopefully so. Is there the directory for those new phone numbers readily available? And because so much of what we do from a scheduling perspective is electronically configured or controlled, how are we going to deal with schedules when that technology is not available to do the staffing, to do the patient scheduling, to manage the OR, etc.? That's another part of our planning consideration. Another critical lesson that we have learned, and I suspect those of you that have gone through this yourselves have learned it as well, that for those of us that have been in healthcare for probably more than 2 decades, pen and paper is how we started. And so we're very comfortable in going back to pen and paper as part of our downtime procedure when it's necessary. But for those who've grown up largely or more dependent upon computers to do their day in and day out work, take that computer away and their comfort level, their knowledge level of what to do next isn't necessarily as readily available. And so bridging the gap, if you will, with the experienced working with the inexperienced, vitally important. You can write to it as part of your plan, but really it's part of what actually just happens more times than not in a real world experience sense. Next page, next slide, please. Other clinical issues include if the system in its entirety is down, then you're going to have some individuals, particularly in administrative offices, but not just in administrative offices, who can't do their work. Their primary tool is taken away. And so rather than send them home, we learned the immense importance of creating a staging area and reassigning some of these individuals to do things like scribing, using pen and paper for our physicians and our nurses, having them answer the phones at our nursing stations, becoming supplemental staff in the clinical units, also serving as runners to take those forms with the specimens or what have you, to keep the staff in place and use the supplemental staffing to be that better downtime alternative runner. We also have found that there are some positions that we need to potentially to send home. In our case in 2016, we regularly sent a pharmacist or kept a pharmacist at home because their internet connectivity worked and they could go online to the various programs that they typically use on a day in and day out basis to make the connection, and then they would call in the information to whoever needed it. We did some of that same type of crosswork, if you will, within our administrative operation as well as our financial operations. Face-to-face communications was another critical lesson that I want to emphasize. There is no such thing in a major incident, and this I think would be a major incident for most all of us. Nothing is going to be more important than effective leadership on the one hand, but that effective leadership is only going to reveal itself through effective communication. And so one of the things that we found particularly important was, yes, we convene an incident management team, but at various points during each shift, we sent those leadership elements, not all at once, but parts of the team went out to the individual units to get a pulse of how things were going, to answer questions, to provide thanks for the good work being done, etc. And we found that in our case, where we were without our principal programs for about 3-day period of time, you needed to not only plan or have a plan for a 12-hour period, but you needed to have an extended operational consideration in your planning as well. So how do I rotate that incident management team across multiple shifts in a 24-hour period? We employ safety teams. How do I replace or rotate them? And we heavily depended upon our medical and our nursing informaticists to make rounds and to be available as our SMEs. How do we rotate those is a planning consideration too. Next slide. Now, while a lot of time and attention is rightfully to be paid on the clinical operations and providing patient care directly, our good plan is going to have to address non-clinical issues as well. How do we, in the absence of our technology, in the absence of our typical applications, order equipment, supplies, and medications, first from the unit to downstairs, but then how to supply chain, order it from the vendors, etc. How do we do simple things like paying for those items that we just ordered is a consideration, but how do others pay us, such as the visitors who are still being seen in the clinic? How do they make their copay? The visitors or even the patients that go to the gift shop, how do they pay, given many of our cashier operations are dependent? Same thing could be said for the cafeteria. Our standardized method of tracking patients both within the house can be on a downtime procedure. How do I track the cost of their hospital stay? How am I now going to be getting the information that I'm getting from a downtime and submit that to the insurance company? These are the kinds of things that we should be talking about with the insurance company, for example, in advance of the outage, and not an emergency phone call going to the various insurance agents that we deal with on a regular basis. And oh yeah, we all still want to be paid despite whatever the outage is for whatever period of time. So what's our downtime plan for making payroll and for addressing the other business continuity activity associated with hospital operations? I will also note in that final bullet, again, we learned from experience that one of the benefits of working in advance with your insurance company or companies is to be clear in understanding what is the type of documentation that they're looking for. And is that documentation solely paper-based, or are they looking for photographs in some cases as well? Next. Now, a lot of us rightfully focus on the hospital itself, but for many others of us, we have offsites that hospital or that healthcare system operates. They're important too. So in this outage, partial or complete, are their systems affected? If so, to what degree? Are they part of our incident management team consideration and operation? Can they even stay open? If so, are they all staying open, or are we reducing our number because of the benefits of doing that? And is there any unique workarounds that we have to address in our continuity of operations on the one hand and our restoration of services on the other? Next. I mentioned earlier about messaging. I want to come back to that because I can't stress enough how important messaging is. I've never been involved in an incident in my 47 years, both in the pre-hospital environment and the hospital environment, where the leadership was accused of giving too much information. Usually it's to the contrary. But in this situation, there's going to be some unique challenges to that messaging mindset. We might want to say certain things because you need to know that. But because this is potentially a criminal act, law enforcement is going to have an impact on wanting you to be constrained in some of the information you share, both within the facility itself potentially, as well as with those external to the facility. Your own attorney may also have input into what your messaging should be, what the wording of those messages may be, etc. And sometimes you may find yourself in the end deciding that it's better to not say something now than to say the wrong thing. But that being said, one of the most important end outcomes of effective messaging is to not only dutifully inform in a timely, concise, effective fashion, but it's also to protect the brand of your facility, of the corporation that you may be a part of. So this messaging scheme is typically going to involve not only multiple different people, but again, multiple different perspectives that in the end, the incident commander is going to have to make the final judgment on what will be said, but who's going to say that message and how is that message going to be conveyed? It can be anything from in person to using social media. Figure it out, but list what the options might be as part of the plan itself. Next. Insofar as that messaging is concerned, before I get off of it, staff messaging is one thing, but how do we message to the patients? When do we message to the patients? In our particular case, we purposely waited a number of hours till we got a full handle on the situation. And then we began to send messages on food trays. We also messaged via individual rounding where the clinical staff provided the initial heads up versus the periodic updates. And then we found ourselves trying to figure out how to deal with talking to the families, both once they arrived versus what do we put out, if you will, over social media. Those are the kinds of messaging considerations and strategies that you need to give thought to as well. What do you say to the community at large is another planning consideration. There's a board of directors that's legally responsible for your operation. What do they get told? When do they get told? How much can they be told? Who's going to do the telling? Your incident management team needs that guidance document, ideally to give some suggestions. And also there's going to be the probable need to notify external authorities. Your local Department of Health will be high on that list. Perhaps even some of your elected officials would be on that list among others as well. Next. Now, at some point, you're going to be in the position that we have identified the root cause or causes. We can fix those causes, and it's going to be time to bring the system or the system itself or the individual application back online. Who's making that decision? Is that locally done at the facility because you control the entirety of the situation, or is it hospital input into what ultimately is a corporate decision? Needs to be clear. We can't, as a rule, and experts advise, in fact, against trying to restore every program all at once. And so having pre-established a restoration prioritization scheme will probably operate to your advantage. But who's made that decision? Do I vary that original pre-incident decision based on incident-specific information? And once I begin that restoration process, it too may be affected by some trial and error, lessons learned, if you will. Also, in that restoration strategy, am I bringing it back up for just one facility, or am I bringing it back up across a system of facilities, including, as I mentioned earlier, not just the hospitals, but the outpatient facilities too? And is everybody coming back on the same time frame, or no, everybody's going to come back, but we're going to handle this north set of hospitals first, then the south, and then we'll do the ambulatory sites. Typically recommended also before programs are brought back online is your remediation team is going to do some testing of the system. So it may be back available for use, but you're not going to be told about it until they've tested it and are satisfied that it's going to work the way you want it to. Next. Interestingly enough, another vital set of lessons that multiple facilities that I've talked to learned is that it's one thing to get through the alert, the notification, the mobilization, the initial response period and how we've planned for it. But in the end, the recovery phase is going to be its own challenge. How do I, on the one hand, have my staff continue to do their day job while now, as programs are being restored, go back and re-enter, or I shouldn't say re-enter, enter for the first time information that they were manually writing down beforehand? We found in many cases, you can't expect one individual or one group of individuals to do both without it being extraordinarily delayed, fraught with error, and a lot of frustration. So among our planning considerations is when we're ready to recover, we're bringing in supplemental personnel so that one group will do the day job that's ongoing, the other now will be tasked with the recovery. And their recovery work will follow the downtime script that was either in the plan originally or maybe have been modified based on the real world experience that we've just gone through. And we have to be prepared that this can not only be labor intensive, but can go on for an extended period of time. In our particular case, and I've heard in talking with others, this recovery period can actually go on for several days, not simply several hours. And then in the end, how did we identify what couldn't be restored? How do we notify the individuals impacted? And is there anything else that we will do in this situation? Most of the time, what can't be restored is probably what wasn't known about before the incident occurred. Next, please. So now you've got this comprehensive plan that's looked at all of the different aspects and the different phases. Who do you have to have approve it? Is it your emergency preparedness committee? Is it your executive team? Be clear, actually, before you started writing, who is ultimately going to do the final approving. Now that you've got a plan that's approved, how are you going to keep it? We would encourage you keep it in multiple forms. In our case, we put it up on the internet. We put it into our cloud storage, and we also print it out, and we also put it, among other things, on over 100 thumb drives that we can pass out, if you will, during an emergency if needed as well. And now that you've got the plan, next. Also, we've got to figure out, how do you train on the plan? And I suspect that we will all come to some consensus around the fact that to train on this plan isn't exactly the same potentially as it would be for our mass casualty incident or for our Code Pink abducted child or missing infant drill. There's nuances associated with it that make trying to turn the system off in order that we can practice our downtime procedures unrealistic for most of us. So what can we do as the alternatives? Next, please. Well, I submit there's not just one way to do it. We've had some success in providing at least once a year training to our mid and executive level leadership. We do a formal exercise where we rehearse when the system's turned off. We also, as part of our emergency management month activities in September, each week we take a different activity, create a scenario with accompanying questions. On one of the weeks, it's all about we've lost our system. Here are the questions, and the leader for each clinical and non-clinical area of the hospital is expected to review the vignette and the questions, and in turn come up with the answers as part of the review process. We also this year are going to be experiencing going on individual units for a specified period of time and rehearsing in a virtual sense. Okay, you just lost MedConnect. What are you going to do as the alternative? So live, short term, but in-person training, spur of the moment and unannounced. And then I would submit one of the things that we probably all might be guilty of is, are we taking full advantage of the planned outages that are going to occur multiple times over the course of a year as part of our preventive maintenance program? Are we simply announcing them and that's all there is to it? Or are we using that as its own drill and having evaluators go out, mentors go out to make sure that everybody is optimizing the experience, learning from the experience? Next, please. In summary, there's lots of things that a comprehensive plan should address, beginning with the who is involved, the what are we trying to accomplish, what's the process that we're outlining for ourselves to get to an end point of having this comprehensive plan, and then in turn doing training and exercising on it. I would submit to any and all of you, if you've not yet gone through the experience of extended unplanned outages, or worse, being compromised by a ransomware attack, being hacked, call it what you will, it's not if, but when you're going to need your plan in turn. Good plan is going to be written and exercised by any and all of the personnel that are invested from different perspectives and experiences to ensure that no element of our operation is being left out of what otherwise is to be considered an emergency response situation. And like any other plans, it's going to be a guidance document. It'll be a continuous work in progress, and it's only going to be as good as the individuals tasked with using it are familiar with doing so. I'm going to stop at this point. As promised, I left some time at the end. So Matthew, I'm going to be quiet and see if we have any questions, or are others that have gone through the experience interested in sharing some of their own lessons learned.
Thank you, Craig. I do encourage all attendees, if you do have questions for Craig, please place them in the chat box now. And as a reminder, the slides I'm recording will be emailed out this afternoon for all those that registered. Craig, currently I don't see any questions in the queue, but we'll give it a few seconds here to see if anything comes in.
Okay.
Hey, Craig and Matt, this is Monica. I just wanted to, while we're waiting for a few questions to show up on the screen, just to mention that I think it's real important to include new hire orientation and onboarding training regarding your cybersecurity policies and plans. A lot of times we wait until an employee has kind of gotten their, their bearings and get their feet wet a little bit. But I think I've heard from a lot of people that their first encounter with the IT event was within a week or so of being hired. So I think just including that, or at least considering how you're addressing those issues with your new hires, is something that we should all take a look at. And as a training and exercise coordinator, I especially appreciate Craig's remarks about how you can best incorporate preparing your staff for these critical incidents by just incorporating your day-to-day briefings, your trainings, the normal opportunities, shift changes, roll calls, anything, your hospital huddles, whatever you call them. Those are easy opportunities, 10, 15 minutes of just addressing one particular portion of your policy regarding the cybersecurity issues and policies, and just making it more of a comfortable conversation with your staff I think that's a lot of the disconnect is people who are not IT folks just kind of shut down when it comes to that. They think it's always somebody else's issue. So I do think this is a great, very informative presentation, Craig. I really appreciate the time and effort you put into this. It is such an issue. I think everyone is aware that healthcare is the highest targeted critical infrastructure sector, and it's continuing to grow mainly because it's highly vulnerable and it's highly profitable. A lot of healthcare systems, they often just pay that ransom because it's quicker than waiting on a complex investigation. So we're all very vulnerable, and I think this is such a relative topic, and I really appreciate your time and effort. And that's
Monica,
all I had to say.
Yeah, I'm just going to say, Monica, let me second your thoughts about the orientation training. We do that both as part of an online education module that all of our staff, not just nurses, have to take. And we also do it as a second part of our emergency management program module as well. And I couldn't agree. We said it at the outset of the presentation that the threat has never been greater. But I would also just point out that while we all rightfully worry about cyber terrorism, just last week, Friday night into a Saturday, my system had an unplanned outage of its major electronic medical record. We weren't attacked, we just had a technical failure. So this planning, while we label it under cyber terrorism, applies to that unplanned outage if you choose to as well.
Thank you, Craig and Monica. We do have a few questions in the queue. First question, Craig, is does your plan include job action sheets for the various positions within the organization?
We have the quick start cards, if you will, that we deploy to the individual units. The incident management team positions are identified as part of our plan, and we would refer to the job action sheets for those incident management team positions to be their guidance, if you will, in addition to using the plan itself. Hopefully I'm answering the question.
Excellent. Thank you, Craig. Next question, are you aware or recommend any plan templates that the registrants today, and you give any recommendations that could be downloaded, or a lot of these plans started from scratch?
Boy, I would have to say, in my experience, most all of the plans start from scratch. I tried to give you kind of a generalized template that you might find advantageous. We all are partnered, if not within a healthcare system. We're all part of a healthcare coalition these days. So if you're looking for a template, you might look to one of your other stakeholder partners and ask them. The other reference that I will encourage everybody to go to is HHS ASPR operates a program called TRACIE, T-R-A-C-I-E. Easily Googled. This is a wealth of incident planning and response information, and they have continued to build up, if you will, a section on cyber terrorism and ITIS outage planning. So you might find some additional help by going to ASPR TRACIE.
And Matthew, I just want to also mention that DHS has a division that deals directly with this threat. It's called the Cybersecurity and Infrastructure Security Agency, and we actually have some contact info. I don't have access to it at the moment. I'm in a training in Danville, but I'm happy to get that out to the participants later for a regional contact for the CISA DHS representative. We had them speak at a previous engagement, and they have really good information. They're able to assist even private industries in certain aspects of a cybersecurity threat. So it's just another resource that we can make sure that our participants today have access to.
Thank you, Monica and Craig. And as Craig had mentioned, I placed the link in the chat box for ASPR TRACIE's website, along with, for those that are not familiar with, Virginia has 6 regional healthcare coalitions. And we do have their contact information at vhas.org/regional-info for you to go on there and touch base with them. They're a wealth of knowledge from training and exercise along with plans. So without further ado, Craig, there's no more additional questions within the queue. I do want to thank Mr. Diatley for joining us today and giving us these great tips and recommendations and information, especially his lesson learned from the events over his experience. And I do want to thank all the hospitals, health systems, and healthcare partners, along with our BDH partners as well, who are able to join us today. And this does conclude the VHEMP quarterly webinar series. We look forward to you all joining us next quarter for our next offering. Thank you.